Cloud. All right. Well, I am delighted to introduce today's speaker. We have Valerie Reyna. Dr. Reyna is the Lois and Melvin Tuckman Professor of Psychology at Cornell. She's also a fellow of the Society of Experimental Psychologists and charter fellow of the Association for Psychological Science and a member of the National Academy of Sciences. She's served as a past president of the Society for Judgment Decision Making, and her work on risky decision making and fuzzy trace theory is well known to us as members of the Society for Medical Decision Making. And today she's going to talk to us about GIST, numbers, and fuzzy trace theory, a new look at vaccination behaviors and intentions. Take it away.
All right. Well, thank you so much. It's a pleasure to be talking to what I consider to be a society of friends. Not Quakers, but friends. They're called the Friends. Anyway, if anyone has any questions as we go along, please just sing out. I have everything minimized, so I won't be able to tell, and I don't mind at all if you ask me what things mean or if something's not clear. So, without further ado, fuzzy trace theory, which I'm going to talk about today, is a theory of memory, judgment, and decision making. And memory just means mental representation. You're using your memory even when you're looking down at a page or looking up at a slide and the information is in your mind. You're already putting it in working memory. So mental representations at any stage, immediately and over the long term, are memories. So there are two main types of mental representations that we posit in this theory. One of them is the gist representation, and those are the fuzzy traces, as in fuzzy trace theory. And gist traces distill information to the bottom line meaning in context. So you see a picture there of, I think, a whiskey distillery. So the idea is you don't just, have some of the information. It's not like mental shortcuts. It's about capturing the essence of the information in a compact, concise, incisive way. So it has to do with meaning. And we've seen more discussion of meaning, meaning of words, meaning of numbers, and meaning of graphs in our field, which I'm very, very heartened by. The other type of representation is verbatim representations. And in verbatim representations, you have the literal, rote, exact details. The doctor said, take this twice a day. You remember the doctor said, take this twice a day. You may not know what that means or why that's the case, but that would be rote or verbatim memory. Now, what we argue more broadly is that communication should target gist, not verbatim literal representations, because gist cues core values, and we're going to talk a little bit about that in this work. It endures over time, it transfers across contexts, and it dominates decisions and is cognitively advanced. So this is not persuasion, however, because the gist of options is distinct from the values applied to the options. So it's in that middle ground of not being the literal stimulus. It is interpreted, but if you're an honest broker, we argue, you're not necessarily persuading. You are representing the information so that the patient can make contact with his or her values. So here's an example of GIST that came out recently. This is Mark Silverman's reply to Brian Sigmund Fisher and JAMA, and these are his words. And I thought this was a really good example of what we mean by GIST. A person infected with COVID-19 had a 10% chance of spreading the then prevalent variant. His question then is, this was the facts at the time, what is one to make of 10%? Is that low or high? And that is a question that we ask, in fact, in the research I'm going to present and in prior research. And this is what Silverman said. He said, here's what I would have explained to a patient. My carpenter takes a 25% chance of rain as the threshold for whether to work outdoors that day. Accordingly, a 10% chance of rain is low. But COVID-19 is not rain. It is a potentially lethal or debilitating disease to have and to spread. And a 10% chance of transmitting it to family, friends, and community may well be a risk you would not want to take. After all, if 1 of 10 commercial flights developed engine trouble after takeoff, would you travel by air? Now, I think that really captures it. It isn't just that it's low or that it's high. It's the whole context around it. It's the family, it's the friends, it's the lethal but also debilitating. It's all of this together combined with background knowledge that gives you a sense for that risk of 10%. So what we argue in fuzzy trace theory is numbers taken literally don't solve the problem of informing patients. They beg the question, what is one to make of that number? Here's another very timely example of gist I'm going to just briefly present. This was from an interview with this gentleman was the former NATO Supreme Commander. And when he asked about the probability, and again, there's been a lot of discussion, a whole special issue of medical decision making on probability and how to communicate it. He was asked about the probability of escalation. And this was on March 28th. And he said, is it inevitable? No. Is it possible? Yes. Is it higher this week compared to last week? Yes. So the categorical gist would be, is it possible? Or also, is it inevitable? Higher this week compared to last week is what we call ordinal gist. One is higher than the other, but not the exact amount higher. And of course, if we had exact probabilities displayed here, that would be the verbatim exact details. So a little background on fuzzy trace theory. I've been asked a number of times, people have asked me, gee, I'm using the word gist. I know I'm supposed to cite something, but what am I supposed to cite? There are different publications. It's hard to sort of keep track of all that. So this is what we used to call in government a one-pager. And the first question is, where does the construct of gist come from in medical decision-making? It comes from fuzzy trace theory. Some people heard it through symposia that we organized with Psychonomic Society. Some people heard it with Wendy Nelson organized some wonderful symposia too. And then there's a number of places that people have heard of it, but there are publications that can be cited. Probably right now, the all-around citation that will fit most needs is the Reyna, Edelson, Hayes, and Garavito 2022 citation that's up there. But also there's an earlier overview in MDM. There's Blaylock and Reyna, which was a review of studies in health psychology. And if you want to go back to the early use of fuzzy trace theory in medical decision-making, the Reyna and Lloyd paper there in 1997 is a good citation. So, and I'm happy to help anybody if you have any questions about this. How are probabilities mentally represented? How does this predict medical decision-making? Well, fuzzy trace theory explains mental representations of numbers. We've done a lot of work on that going way back, including frequencies and probabilities, and that's relevant to medical decision-making. There's the Psychological Bulletin Review, a couple of other papers, Origins of Probability Judgment paper in 1994, and then the Learning and Individual Differences Overview in 1995. Fuzzy trace theory explains how numbers determine decisions, and here's some recent references on that. These two, this allows you to not have to wade through lots of other things. Reyna, Muller, and Edelson, and then Reyna 2025, Journal of Behavioral Decision Making. That's probably the most up-to-date version of our mathematical approach. And then fuzzy trace theory explains how numerical comparison changes decisions. And there's a wonderful recent paper by Peters, Hahn, and Lee, 2025, in Journal of General Internal Medicine, which is all about numerical comparisons. And that is very much akin to what we've argued in earlier papers. I've given one here, the Reyna et al. 2021 paper, because it directly manipulates whether there's a comparison, a numerical comparison or not. And that's a follow-up of Peters and Levin, and I'm going to talk about that a little bit in a minute. But that's directly on point, and we make very specific predictions about numerical comparisons, namely that that's the source of gist. And more specific predictions than that too in these models. So next question, why is literal thinking about numbers not ideal? Why isn't that advanced cognition as opposed to the gist, which is what we argue based on developmental evidence, based on studies of novices versus experts? Experts and adults compared to children tend to lean more on gist than on verbatim. Why is that? Wouldn't exact numbers be the most advanced thing to do? And there's a summary in Nature Reviews Psychology putting together all that evidence across multiple areas of work. And then where does the idea of part-whole confusion and ratios come from? Many people have tried to come at that. We started working on it, I hate to say, 1990 was our first paper on that. and 1991, we applied it to the conjunction fallacy. That 2008 paper summarizes it. We talk about these part-whole confusions, which are part of every probability judgment because they're about ratios. The numerator is contained in the denominator. So that's a part-whole relationship. And we argue that confusion brought on by interference about that produces some of the many effects that are very important to our field, such as denominator neglect. And then finally, how does fuzzy trace theory differ from system 1 versus 2? A while back, we called them both dual process theories, and they are, but GIST is not system 1. GIST is about a mental representation that's extracted in parallel with verbatim representations, and it's not the mental shortcut kind of approach of system 1. So Reyna, et al., probably in a 2025 paper, that directly contrasts the system 1, system 2 approach with data on the cognitive reflection effect. It's a study of accountants and students and so on, but there's direct relevance to medical decision-making. So after that whirlwind tour, let's do a concrete example. So how would you rate a treatment for a fatal disease that had a 10% probability of success? Suppose I told you all the numbers and facts, etc. 1 to 7, how would you rate it? Most people would say, that's terrible. A 10% chance of success for a fatal disease? Yuck. What about if I told you that the same treatment, the same probability, the same facts, had all of that, but the other option is certain death? Now, how would you rate the same 10% chance of success? You'd probably rate it great. And this is about the relativity of GIST. Whether it's terrible or whether it's great depends on compared to what. It's the relativity of GIST and numerical comparisons. And we've written about this over the years. And again, this relates to that JGIM paper that I mentioned too. So this comparison came up actually in a symposium. I don't know if many of you remember, I hope you do, Mike Catan. And he said that he faced this exact decision in his life where he had to take an experimental treatment. He said in this symposium, right after I had made this claim, that it wouldn't have mattered what the number was. It was the only possibility of life for him. And therefore, it was a wonderful option. And we remember him very fondly. Anyway, in that experiment in Reyna, Brainerd, Chen, and Bookbinder, we showed this effect, how it was predicted by fuzzy trace theory. And I should say more broadly, all of the papers we've written on mental representation include this idea that the GIST is by comparison. So when you think about a framing problem, you know, your classic framing problems, dread disease problems, and so on, 200 saved for sure versus a 1/3 probability, 600 saved, 2/3 probability, no one saved. You justify this down because saving some people is compared to saving none. That's the contrast, and that drives the categorical GIST. If you change the options, you change the categorical contrast. So GIST has always been predicted to depend on the context of the other options, and we've spelled out the steps in various models. So without further ado, now that we've done a little background, I'd like to talk about vaccination. And this paper that I'm going to talk about and my wonderful co-authors, I want to underline them. They're terrific here, Adelson Garavito, Galinda Singh Fang Su. In this paper, they were, tremendous contributors to this. And the paper is available open access if you'd like to read it. So what about vaccination? Well, viral outbreaks are increasing, but vaccination rates are decreasing. This seems to be a real perplexing state of affairs. This downward trend in vaccination started before COVID-19, but it accelerated during the debut of COVID-19. And now it's cascaded to other vaccinations, things you would think would be less controversial, like the flu vaccine that we study here. This behavior is baffling because it seems to contradict, the fundamental core axioms of most of our theories, which is that certainly people would act in their rational self-interest. Now, of course, there's been a lot of development since the rational core theories, but it still remains baffling that especially when the outcomes are lethal, why would you not act in your own self-interest? So this certainly is not covered by rational choice theories. So we tested alternative theories in two samples, a young adult sample, and these people are major viral vectors, even if they have a lower rate of death from things like flu. Some do die from flu, but then they are hospitalized, but they do also spread the disease to many others who then are at tremendous risk. And we had a sample of community members, 185, that we sampled on the web and in various other ways. Our key predictors were intuitive in that they were gisty, imprecise, and non-analytical. And we contrasted these predictors in regression analyses with rational system 2 predictors, numeracy and cognitive reflection. So if you remember the bat and the ball problem, et cetera, those are the problems we used, which is the most commonly used measure of cognitive reflection. As I say here as a preview, these rational system 2 measures were not predictive. FDT predictors explain substantial variance controlling for other known predictors, like demographics, accessibility, knowledge, system 2, as I've mentioned, and social norms, which we thought might be particularly important to young people. And then finally, FDT, we think, demystifies these choices somewhat. It identifies points of intervention and explains why scientists are sometimes the ones who don't get it. So why is vaccination so vulnerable to begin with? Well, we live in an information marketplace that has so many ways of spreading information very rapidly. Bots, social media, there's news influences, of course, that are part of the mix. And, we've studied AI tools, and we're currently studying AI tools as part of a Trails Institute. It's an NSF Trustworthy AI and Law and Society Institute. And we're looking at ways that AI tools can not just propagate misinformation, but propagate good information, including health information and the effects of that. So that's a backdrop to everything we're saying. So that's the sort of landscape in which we have to operate with our research on vaccination. There's social media out there. However, some of the good news is that social media messages, for example, about vaccination and measles and things like that, spread more beyond effects. So messages that have gist in them spread more than messages that just have numbers or stories or images or emotion. So this is a couple of papers. There's others that I mentioned by Barniatowski et al. In Vaccine and by Ding et al. In Human-Computer Interaction. And there they work by Eugenia Rowe and others followed gist over time and linked it to things such as vaccination behavior. So the gist propagates over these social media networks, and that can be a force for good, but it also can be a force for not so good. And I'm also going to argue that not failing to vaccinate. Now, some people shouldn't vaccinate for medical reasons and other reasons. Maybe there are other religious reasons and so on. And I'm actually not talking about that. I'm talking about people that, if they really understood the gist of the facts, they would vaccinate. And that effect is not that the people are cognitively lazy, irrational emotions, or dumb system one heuristics. I'm not saying that never happens. I'm just saying that there are other major factors that determine this behavior. And that fuzzy trace theory, we hope, helps explain this vulnerability and we hope it goes beyond prior theories as well. And so the key two parts of the recipe is that the gist of the information plus core values determines behaviors, and it also determines emotions. And emotions sometimes are appropriate reactions to the gist of the information. And therefore, we argue that bringing along hearts and minds is crucial. We certainly, there are many laws and policies involved. But if you don't bring the hearts and minds of people along and you just put in mandates, it creates social unrest in ways that ultimately the system can crumble and you don't achieve the goals that you'd like to achieve for the greater good. So what are the variables we've talked about here? Well, to begin with, we have background variables that most modern theories have would agree are important. Things like accessibility. We measured self-efficacy to get vaccinated, perceived behavioral control to get vaccinated, affordability, I can afford to get vaccinated. So that's all under the rubric of accessibility. Knowledge is extremely important. Knowledge is not sufficient to change behaviors often, but it's necessary to change behaviors. So some theories treat knowledge as an end in itself. If you fill up the bucket in the mind with the facts, the behavior will follow. We think about knowledge, especially the kind of knowledge we tested here, as background. This background knowledge acts as a filter, an interpretive filter that helps people see the gist of the information they're given. And this goes back to some classic work in cognitive psychology by Bransford, Franks, and others. So we looked at how to manipulate the form of the question and the form of the response in order to achieve predictive validity. So very important, we ask global questions about risks and benefits with crude responses. This is in order to tap the gist that's stored in long-term memory. So we ask the questions of people, overall, for you, which of the following represents the risk of getting a flu vaccine? None, low, medium, or high? Now, notice this is not a rational evaluation measured on a continuum, et cetera, per theory of reason action or theory of planned behavior and so on. In fact, in those theories, this would not be a sensible question. It's too vague and ill-formed. What context, so on and so forth, are you talking about? But people find it possible to answer this impossible question. They readily answer it, and as you will be able to see shortly, it predicts their behavior and their intentions. Now, one of the reasons this is effective has to do with memory retrieval. This is called encoding specificity. When the form of the question you ask and the form of should be form of the response together cue the retrieval of gist representations and core values in long-term memory, you can bring them to the fore. So one of our earliest examples, and this is a real patient in the emergency room. They were in the emergency department. The doctor asked the patient, are you taking ibuprofen? That was actually the resident. And then the resident went out, and the attending came back in and said, and the patient had said, no, we're not taking ibuprofen. Excuse me, I'm going to turn that off. Sorry about that. Anyway, so are you taking ibuprofen? And the resident asks the patients, and the patient says no. And then are you taking something for pain? The attending says a few moments later, and the answer is yes. And the attending says, what are you taking for pain? And the patient says ibuprofen. So this sort of thing demonstrates the importance of the retrieval cue to tapping the values that people have in memory. So it's a combination of having the values and then retrieving the values in context. So because of the fuzzy processing preference, asking questions in a gisty way is more likely to predict decision-making. So here's another set of measures that we asked and why we asked them. Gist principles. Gist principles capture core social and moral values stored in long-term memory. And again, the form of the questions, as simple, imprecise, these act as retrieval cues for core values. These are the kinds of values you were taught in kindergarten. And we have them in that simple form, uninstantiated on purpose, because we think it's the match between the value and the representation of your choices that guides behavior. So core values are not the elaborated situation-specific values in other theories. Instead, they're very basic principles like, I don't want to hurt other people by giving them the flu, by not vaccinating, this sort of thing. So values and gist principles are internalized. So they differ from social norms when the norms are about conformity or social pressure. So for example, I'm not vaccinating because my friends or parents would disapprove. We also ask people about social norms so we can look at whether social norms predict beyond gist principles. They're related, but they're not exactly the same concept. And by the way, to preview, yes, they do. So we'll talk about that when we get to the results. So finally, well, not quite finally, but there are more FDT constructs. We also ask about what we call a status quo gist. And this gist is um, based on framing problems. For example, like I said before, where you have a good outcome for sure, or you can take a chance and you either have a good outcome or a not good outcome. The not good would be saving no one in the framing problem. And obviously, the good outcome is better than the not good outcome, so you pick the sure option. So there's lots and lots of evidence now that those decisions are based on categorical gists, something good for sure versus the possibility of nothing. When you apply that same kind of categorical gist to vaccinations, if you're not informed about the nature of prevention, it can boil down to a status quo that's not vaccinating, promoting. And that's of feeling okay. You feel okay when you're going to get vaccinated. You're not sick. If you get vaccinated, you take a chance. You could either feel okay after vaccinating, or you could not feel okay. This is someone's, possibility they might have a side effect or react badly. Feeling okay is better than the possibility of not feeling okay, just like it is in the framing problem. And again, this favors the sure option, which is not vaccinating. And we found in previous work that this categorical gist predicts intentions and behaviors in other prevention contexts, like cancer screening, for example. And there's some references there, arthritis, and so on. So in this study, young adults, 722, 18 to 28, these were college students. They were somewhat diverse, 60% white, about 30% Asian, 11% were Hispanic. Community members were a much wider range of age. They were 20 to 76, average age 40. They were somewhat diverse. And the numbers, the percent Hispanic was 10%, for example. And substantial numbers in both samples had not been vaccinated, which was interesting. All right, demographics. Just to give you a little preview, we occasionally found effects of demographics in predicting vaccination intentions and behavior, but they were not very large and not necessarily consistent. But in general, women had higher intentions than men. White respondents had higher intentions than not white respondents. Black respondents had lower intention than not Black respondents. And older people had higher intentions than younger people, which is, of course, makes sense given the nature of the risk and the messages that older people have received about vaccination. Accessibility included things like 4 items. I would find it difficult to obtain a flu vaccine. I would find it difficult to afford a flu vaccine. These 4 items had very high Cronbach's alpha, 0.905 for the young adults, 0.908 for the community members. That's accessibility. We assessed knowledge with a 51 item scale relevant to vaccination, all the background information we thought that might be relevant. There was a 5-point response scale. We say here from false to true, and you're probably thinking, how could that be a rating scale? That sounds dichotomous. Well, it was false, probably false, neither true nor false, probably true, and then true. So that was the degree of truthiness in that scale. And it was things like getting the vaccine will weaken my immune system and make me more susceptible to other illnesses, reverse scored, of course. And the alpha for that was also very high, about 0.89 in young adults and 0.935 in community members. So key predictors. These key predictors were the single item global risk question that I mentioned to you before. Overall for you, which of the following best represents the risks of getting a flu vaccine? And again, the answers were none, low, medium, high. Again, a global benefits question worded exactly the same way, single item. Then the GIST principles of social responsibility scale, which were 11 items. You should not hurt other people by giving them the flu. And the alpha there is 0.909, which suggests that all of the items had pretty much that GIST. And then we asked the status quo GIST questions. These are 3 items, and they're the I feel fine now, so it's unnecessary to get the flu vaccine with the possibility of not feeling fine. And that was 0.852 in the young adults, Cronbach's alpha, and 0.819 in the community sample. And there are even more predictors of vaccination. There's quantitative risk on a 0 to 100 scale. Here's where alternative theories say you have to think about, well, what are all the common consequences that could happen? Like, for example, using theory of planned behavior. And each one of them, and we average them together. So the probability of a side effect, the probability of dying, the probability of getting hospitalized, all of the major ones. And that had remarkable reliability as well, 0.907 for young adults, 0.900 for community. The subjective numeracy scale was used, your familiar scale that I bet most of you know, the 4 items rating your ability, the 4 items rating your preferences. Altogether, it again had really high reliability, and this is the Fagerlin et al. Scale. And then the cognitive reflection test. This is the classic version of the cognitive reflection test. There are only 3 items, and they're dichotomous. By the way, I put alpha in here because the Cooter-Richardson scale amounts to Cronbach's alpha mathematically anyway, even though they're dichotomous. And that's 0.747, which is pretty good for 3 items that are dichotomous. And then descriptive social norms. And these were single items. When we collapsed them together, they actually didn't predict better than when we used them individually. They were predictive individually. So there were 2 items that were descriptive, namely, most of my friends or most of the adults who are important to me have gotten the flu vaccine. That's descriptively what have they done, and would I conform to what they have done? And then injunctive social norms are, what do people who are important to me, like friends and other adults, believe you should do? You should get a flu vaccine. And those were 2 items. So the outcome measures, that's what all of those predictors are predicting, are intentions to get vaccinated. There were 6 items, like, do you intend to get a flu vaccine at the start of the next flu season, and variants of that. So the alpha was 0.944 for young adults, 0.974 for community members. And then behavior was a single item, yes or no, or I don't know. And we scored, I don't know, there were very few I don't know responses. We scored them as no, we scored them in different ways. It didn't make much difference. But this single item in the past year, have you had a flu vaccination? So those are our 2 endpoints. So results at last. So just looking at the bivariate correlations for 2 background variables, accessibility and knowledge, and these are all significant. I didn't put the little asterisk in, but they're all significant correlations. So there's a significant relationship for the young adults and for the community to vaccination intentions. And all of the things I'm going to present, they were for the bivariate correlations. All of the behavioral correlations were significant as well, but just lower. So as you can see, they were significant for both samples. Accessibility to some degree predicted vaccination intentions. Interestingly, for the community sample, the correlation with behavior was higher than the correlation with intentions. And that suggests that it's not a matter of intentions with accessibility in the community, where insurance and whether you're rural and so on varies more. It's more a question of accessibility in terms of intentions. Like, actually having access makes more of a difference in acting on your intentions, which I thought was an interesting result. And then knowledge. Knowledge had an enormously high relationship, and this is objectively assessed knowledge, both in young adults and especially in the community sample. That's a very high correlation. So what about the FTT predictors? Well, global risks is on the left. Those were significant, negative. The more you thought for you there was a risk of vaccination, the lower your intentions in both samples. For global benefits, very powerful correlations. The more you thought that the benefits were higher for you, the higher your vaccination intentions. And remember, this is only a 4-point scale, none, low, medium, and high, but very powerful relationships. And then in GIST principles, also very high. This is the GIST principles of social responsibility. So it's a bad idea to hurt other people, very high correlation. And then the status quo was pretty highly correlated for only 3 items, negatively. The more you agreed that if you feel fine, it's not necessarily to get vaccinated, or you don't want to take on that possibility of harm, the less likely you were to be vaccinated. So then we did a series of nested regression models, and I'm going to go through the 3 models pretty quickly. We entered demographics and other background variables, And those accounted for a small amount of variance, significant. When we added the FTT, fuzzy trace theory key predictors, global risk, global benefit, just principle, status quo, there was a significant jump in variance accounted for, 0.58 and for intentions, 0.319 for behavior. This is in young adults. And as you can imagine, global benefits and GIST principles were associated with higher intentions. Global risk and status quo GIST were associated with lower intentions. And when we added in the third hierarchical model, social norms, it in fact accounted for additional unique variance, small but significant increases in R squared. So injunctive norms, for example, were associated with increased vaccination intentions and behavior. All of the social norms were associated with increases. And those were, unique variants. So this is just model 3 to show you that we have some demographics that remain significant. And if you go down to status quo, GIST principles, global benefit, global risk, quantitative risk, and then social norms are significant too, down to the standardized betas. Quantitative risk, interestingly enough, when you throw all of these together, reverses in sign. When you look at it bivariate, it goes in the same direction as global risk. But now it's a little bit higher quantitative risk, makes you slightly more likely to intend to vaccinate. And that is a paradoxical relationship between these two that we've observed before. And we can't say for sure in this sample, but it appears to reflect two ways of thinking about risk. The GIST way, which seems to drive most of the predictions for flu vaccination and behaviors, so the higher you view the risk of, the higher you view the risk of this vaccination, the lower the behavior of engaging in vaccination. Whereas if you engage in the vaccination more, you'll have a higher risk. So there's your behaviors, if you're getting more vaccinations than the next person, say, for example, they had none, they had no risk of vaccination. So it's contrasting that kind of attitudinal risk or GIST risk with this quantitative risk, which seems to reflect behavior. But that's kind of a nuance. The main point here is that the key predictors are significant and they accounted for unique variance in model 3. Similarly, for behavior, status quo, GIST principles, global benefit, global risk, again, accounting for unique variance when you take all the other factors into account, and social norms as well. And then in the community, we had similar, but probably fewer significant predictors, but a significant increase in R squared to 0.800 in variance for attentions and to 0.582 for behavior. So looking at that model 3 here, you can see that status quo is significant, GIST principles is significant, global benefit is significant, and global risk misses significance. It's 0.059. And if you look at behavior, you see that GIST principles and global benefits are both significant predictors, but global risk is not, and status quo isn't. And again, this is predicting the single item of behavior. Did you vaccinate in the past year? And it's about 59% of the variance just with those predictors. So if you look at simultaneous regressions, you might think, well, there's correlated variables in here. Maybe there's some odd effects. So if you just put in the FTT key predictors, so that would be GIST principles here. This is a standardized beta for intentions on the left and vaccination behavior on the right. You can see the same pattern of results. Young adults, the GIST principles, global benefits, global risk, status quo are significant, and quantitative risk in the opposite direction. And for the community sample, they're all significant, but quantitative risk is not significant. So GIST principles predicts intentions in the community, global benefit predicts intentions, global risk predicts intentions, all unique variants, and status quo predicts intentions. And then when you turn to behavior, you can see that now the only two, for the community, the only two predictors of behavior when you only consider the FTT variables are, again, GIST principles and global benefit. And they're standardized. That's the unstandardized beta. Here's an odds ratio for the exact same data. And you can see the odds ratios are lower than 1 for the negative predictors and higher than 1 for the positive predictors. And the variance accounted for is substantial. All right. What about those single questions? Well, we thought we'd take a look at how diagnostic those two global questions would be. This is for you overall. The global benefits are none, low, medium, high. Overall for you, the risks are none, low, medium, high. And if you think about it in terms of qualitative gist, if the benefits to an action are none or low, why would you do it if you believe the benefits are none or low? So that should get you a no, I'm not going to vaccinate. On the other hand, if the risks of a behavior are medium or high, that also would suggest don't do that behavior. That's a risky behavior. So again, the answer would be no, I'm not going to get vaccinated if you believe that, if that was your gist. So that leaves benefits being medium or high. This is the green area here. And the risk being none or low. That's your sweet spot. That's where people probably would vaccinate. Otherwise, no. And I'm trying to get the idea here of purple because they overlap in the lower left there. So if you believe that the benefits of vaccination are medium or high and the risks are none or low, that would be a positive test result. We're making positive in this scheme of coding. So we dichotomized the intention scale so that we could test, do the answers based on these assumptions, how accurately do they predict intentions or behavior? We dichotomized the rating scale for that. And as you can see for both samples, and so behaviors in blue, intentions are in orange, and this is the basically accuracy of these single questions combined the way we just said. So the sensitivity is higher than the specificity for both samples, although intentions is pretty high in specificity even for the community members. And as you can see, your positive predictive value is about in the range or higher than many clinical tests. So if the person says, I think that the global benefits are medium or high, and I think the risks are none or low, there's 65% of the time they vaccinate, and their intentions to vaccinate are over the midpoint 82% of the time. Conversely, if they say no to either of those questions, they're not likely to vaccinate. That would be the negative predictive value. And these statistics capture the accuracy, the diagnostic predictiveness of these two simple items. If you ask someone the question based on our samples, this would be the probability of their intention or their behavior. So what I would argue, these are 76%, 95% over here with the community, and 83%, 82%. That's remarkably high. So we were kind of amazed that two simple just questions could have that much diagnostic validity. So to discuss and conclude, vaccination intentions and behaviors seem to contradict rational self-interest, but psychosocial factors explain them. So if you thought a behavior was risky and of little benefit, you probably wouldn't do it. It would make sense not to do it. It seems more rational when you think of it that way. And if you're thinking of something other than your own self-interest, you would agree with the gist principles of social responsibility. If rationality expands to include not hurting other people beyond yourself, then it makes more sense that you would vaccinate in that case. So simple core values, strongly predicted, higher intentions, and the retrieval cues in the just worded questions were more likely to tap these core values. We think that's one reason why they're successful. Also that they capture a relevant attitude and a relevant core value. Conversely, endorsing a status quo gist predicted lower vaccination rates. And this is really a breathtaking lack of insight into the nature of vaccines. When you feel okay is when you're supposed to get vaccinated. Once you're sick, it's too late. So it's not a treatment, it's a prevention. And that's a basic core gist. Also, global gists of benefits and risks consistently predicted. They carried some diagnostic value. We think this is because people store in their mind an impression of the gist of the benefits and risks of vaccination. if we asked even people who were members of the Society for Medical Decision Making what the exact benefits of vaccination were for them, or the exact risks of vaccination, they might have trouble coming up with exact numbers. In fact, people have argued that there isn't any benefit for the individual, that there's only a benefit in the aggregate. I would disagree with that. But details fade and exact probabilities are often just not available. So the ability to use the gist to make decisions makes practical sense as well as psychological sense. Finally, social norms. Social norms really did predict beyond these gist predictors, which suggests that social influences or pressures can override individuals' beliefs, attitudes, or preferences. And they had strong effects. There was, however, no evidence of system 2 override, which people have talked about a lot as being relevant to things like health behaviors and intentions and behaviors and vaccination. We don't argue, however, that numeracy and cognitive reflection are unimportant. We've certainly found significant roles for numeracy and cognitive reflection in other studies, but we think in this context of flu vaccination, it simply did not play a primary role due to the fuzzy processing preference. So, in conclusion, we think we offer a new look at vaccination, a new set of predictors. These remain significant controlling for predictors that are present in other theories. The decisions are apparently intuitive even for those who vaccinate. They have a gisty, fuzzy impressionistic thinking about their options, and very simple values seem to matter more than reflective reasoning and analytical acumen. And we think this has implications for policy. When you impose mandates on people in ways about things that they don't understand why the mandates are mandated, they can resent them because they seem arbitrary. They don't see the meaning behind the policy, and that produces sometimes a backlash or just lack of compliance. So we think that policy and practice can benefit from understanding how people think and therefore how they feel and why that determines their choices. Thank you.
Thank you so much, Valerie. I will open the floor for questions. We've got about 10 minutes left.
Oh, thank you so much for all the hands. I really appreciate it.
Yes.
We can clip that ringing out of the
It's
YouTube,
funny.
right? Anyway, never mind.
I couldn't hear it very well, so I
Oh,
think it was
good,
loud on your
good,
end.
excellent.
Yes.
All right. So if somebody has a question, should just sing out. There's something in the chat, I think.
Yeah, there was a request for references that you could go back and take a
If you
look
would
at
have any
that.
research, yes. Oh, I reference prospect theory a lot. Absolutely. The Reyna, Mueller, and Edelson paper 2023 references prospect theory a great deal and does an enumerated set of contrasting predictions with prospect theory, for example. That's in Cabin. Oh, I think Aaron has a question.
Maybe if I can unmute. Great presentation as always, Valerie. And yeah, it's interesting to think about how like your talk and my talk intersect in terms of the gist and how so much of the decision making occurs, kind of just at a gut level. But yeah, I mean, one of the things I was amazed at in your study is just the amount of variance that was explained. I mean, anytime you can get, above 30% in explained variance for like, behavioral stuff is pretty amazing. And so yeah, it's super cool that you can get as much explained variance as you can with your measures. So I just wanted to make a comment more than have a question, I think.
Thank you. Thank you so much. I was surprised too. There's so many other factors that we didn't measure. We really tried to, cut to the chase and apparently, we did at least for these two samples and it did replicate. So, by the way, you said gut response, and that's interesting because I think system 1 is a gut response and just as more an intuitive grasp of the meaning. It does have that gut feel. It's often unconscious. It's unparalleled. It has a lot of those characteristics for sure, but it's more of a meaningful essence than it is just like dumb shortcut kind of thing, right? So just to make that little nuance.
You're right. Poor choice of word, yeah, my part, I totally agree. So
Yeah. Laura?
Hey, great presentation. That was really fun and really clear and nice. Your data reminded me of a pet interest that I have, which is that across all data sets that I've ever collected that involve perceived risk, perceived benefit in an intention or a behavior, perceived benefits always predict the intention or behavior more strongly than the perceived risk. And the effect size is usually like double for perceived benefits, which is about what you were observing too. And I was wondering what you think about that.
Yeah, I found that a lot. I found that in a review I wrote in 2006 of adolescent risky decision making. The
Yeah.
claim was that adolescents are impulsive and therefore their perceptions of risks and benefits really aren't what's driving behavior. It's their impulses, right? It's the situation and all that. It turned out that their perception of the gist of risks and benefits did predict their behavior. And exactly as you said, the benefits were multiples of the risk. Risk was, this is across many studies, not by me, but like everyone's studies.
Mm-hmm.
So that does seem to be the attraction to something, the benefits to it. So when we say as expert that there's no benefits to the individual, and then we wonder why people are not running out to get vaccinated, perhaps that might be an issue. I
Mm-hmm.
think we have to think about emphasizing benefits and the gist of the benefits for the individual if we want to encourage these behaviors across a wide array of things.
So why do you think benefits are more predictive than perceived risks?
Well, we talk about teenagers as being reward seeking, but I think we're all reward seeking. That's the reinforcement that we were designed to pursue as individuals.
I find
The
that's
brain, yeah, the
I find
brain
it
is,
so interesting. Sorry, I'm
yeah,
interrupting.
go ahead.
No, I want to know your answer. You're the speaker.
No, I want
I
to
was
know
just
your
gonna
answer.
I was gonna contrast it with, some of that older psychological literature suggesting that bad is stronger than good. It has a greater impact on us. It looms larger in our minds. And so you would think that risks would be more predictive, but
I think we have to disaggregate those concepts. I think the value function might indeed be steeper for the losses and the gains, but the motivation, so there's drive, there's motivation, and there's the psychophysics of values. And I think sometimes they coincide and sometimes they don't, right? So I think there's something about the psychophysics of the value function that has to do with, the loss being steeper than the gains. But the drive toward the behavior, the motivation to seek the reward, I think plays out, is not the same thing as that necessarily. But
Might be.
I'm actually working on some things where I'm trying to disentangle those.
Yeah, I was wondering if the context matters because a lot of times, like, in vaccination or cancer screening, it's about prevention. And so focusing on the benefits in that context might be more effective versus, when, you know, people will do anything they can to get rid of cancer once they have it, which in case kind of, um, you know, insensitivity to risk. Although I guess that kind of reinforces the view. So yeah, I don't know. I just was wondering if the context matters on whether people tend to focus on risk or benefits more. But
Okay, I think you have a question.
Yes, great presentation. Thank you. You mentioned the gist-based processing, so I'm curious about the affective dimension. Do you see the affective like gist as distinct from the cognitive gist? How might that change the way that we design the vaccination?
I'm so glad you asked that question. I think emotion's so important. I think we take a little different view of it. We integrate the gist with the emotion. We think gist is not just emotion, although bad, good is a valence you encode all the time automatically. Going back to the old Charlie Osgood work on semantic differential. Hal, do you remember that? You remember that
Yeah.
work by
Oh,
Charlie
sure.
Osgood?
I remember it, but I don't think we ought to disclose our age, Valerie, in order to
I
say
studied
that.
in school as a toddler. Anyways,
Oh, oh, I see. You are very precocious, so you studied
yes,
it in kindergarten. I
I was
see.
reading psychology when I was 9. Anyway, so I think we automatically encode affective valence, but I think most of our emotion is a result of our gist, meaning you interpret events. Events are often ambiguous. You have to infer intent, you have to interpret something as a barrier to you achieving your goal. If you're angry, there's all these schemas that apply. I think that's very intimately tied with the gist. And this is why cognitive behavioral therapy targets how you interpret the world. I think, and I work with Yulia Landa, for example, who's a cognitive behavioral therapist, who believes that it's a question of getting people to see the gist. That's, an adaptive approach for them. So that's one way you manage your emotions. That's the source of your emotions. So if you convince somebody that something's a dread risk, they should feel fear. They shouldn't be so overwhelmed that they cannot act. That's where you have self-efficacy has to come into play. If you say something's an outrage, then they should probably be angry. That makes sense. It's like laughing when you get a joke. The emotion makes sense in light of the gist of the information. Does that? Yeah.
Yes, thank you.
Well, thank you very much, Valerie. We really appreciate you sharing all of your knowledge and insight and your recent data with us as well. I think we have one more Decision Psychology SIG coming up this semester, and then we'll probably take a break for the summer and then reconvene again in the fall. So thank you all for your attention and your attentiveness and your joining us in these presentations, and we will see you again next month. Thanks again to our speaker.
Yeah. Thank you so much, everybody, for coming, and I would love more feedback. Please send me any feedback you have, including critical. Thank you so much. Take care.